India, Dr. Manish Pandya, sir.
Thank you, thank you.
We, along with our entire team of Portobello Maternity and Women's Hospital, are truly honored to share this moment with you, sir. Dr. Manish is professor and HOD at Scientific Research Institute. His various awards and achievements include Dynamic Indian of the Millennium by KG Foundation, Guided Excellence Award by Foxy 2020, Commendable Editor-in-Chief by IESRF in 2021. He is also author of various books with total 56 scientific papers in his name. The work that you do as a specialist is truly remarkable, sir. Over the next few minutes, Dr. Manish will be giving an enlightening session on the topic redefining treatment paradigms in management of miscarriages. Thank you, sir, for being here. Now, may I request Dr. Manish, sir, for your enriching session.
Thank you. Am I audible? Because caller mic is coming and there is a traffic and there is a stagnation. So better I use my own voice. Timelai kasto che. And second, Tape something yes. All are will be happy. So thank you very much. Thank you Sri Prasad for giving me opportunity. Thank you Abbott. कहाँ गया Abbott का बंदा? गया. So thank you Abbott for giving me opportunity. Today morning I had done very good darshan at Pashupatinath. So I am a Silubak. So thank you for giving me opportunity to be here at the Pashupatinath. The moment child is born, mother is also born. Am I right? She is there. Mother is something new. So if somebody asks, what is the age of your child? Or someone asks, what is the age of your mother? What it will be? The same as the child of your first child born. But before that you are there. After child born you are mother. So मेरी माँ की उम्र कितनी? उसके मेरे दो से जल्दी कर. बाद में जल्दी का मामला. Okay, so thank you very much. Three books written by me is recommended. Hello. Yeah. Three books written by me is recommended at Royal College as a reading material. Namaskar, madam. You are actually madam. So you are government, but you have done too much service in Paropkar. Paropkar in Gujarati is Upkar to somebody else. Same here. So Paropkar, Prasuti. In Nepal, if you ask anyone, where you born? Prasuti. Where you born? It is Prasuti. This is book of Atlas of Fetal Echocardiography has gone for second edition. The technique of IVF made easy is very much appreciated by Prasad sir. Madam, आप आगे आइए. Madam, आप आगे आइए. You are fine. Okay. Thank you. So this is technique of IVF made and this is now available as a second edition and it will be available in market soon. Okay. I am editor-in-chief of Jew Journal. So if anybody wants to write any paper, they can contact me. This is Indian Journal of Obstetrics and Gynecology and this is also coming in Scopus. And somebody wants to have publication internationally, this is Open Access Journal in Obstetrics and Gynecology. It is publishing from Michigan, US. Those who have got dollar, they can publish here. Recently in Ashray, Copenhagen, I got opportunity. You all become member of DocFlix. DocFlix is just like Netflix of doctors. Every day you will get different presentation in DocFlix. And if you wish, you can become subscribe Manish 4269 YouTube channel. There are lots of videos of live presentation and this video will also go tomorrow or today evening on YouTube. So you can see all my presentation live. This is Ashray presentation in Copenhagen and I am happy that I take an interview of Professor Herman Durne in Ashray. Today what we are going to do? We are going to take one good case. What is the rationale of use of dydrogesterone? What is immunomodulatory effect of dydrogesterone? What is clinical benefit of oral dydrogesterone? And choosing innovator dydrogesterone over the generics. This is typical case. You might see this case in this scenario also. Madam, 35-year age, BMI is normal, 28-day normal cycle, married for 10 years, but no living children. If you ask the history, she is gravida 3, para 0, living 0, abortion 3. If you dig into the history,
She says that there is 2 years ago there is complete miscarriage at 8 weeks. 1 year ago miscarriage at 14 weeks and she required DNC. And 6 months ago she has got miscarriage at 10 weeks. Now at present, madam, she is 5 weeks of MNO. Okay. So what you will do as a consultant? You will examine. As a student, what you will do? You will ask the history. Can anybody give you the history of definition of history? History is then, and Nepal has got history, India has got history. So what is the definition of history? 100 rupee price. Just like suppose I will ask what is the definition of normal level. What you will say? It is a series of events that occur in human genital tract to expel out the viable product of conception from uterus through cervix, through the vagina into this exterior with minimal effort. This is the definition. मैडम हिस्ट्री का डेफिनेशन एक तो बोलो हिस्ट्री में से हमने कुछ नहीं सीखा, कोई बोले इतिहास में से हमने क्या सीखा, क्योंकि कुछ नहीं सीखा, एवरीथिंग फॉलो हिंदी ना. So what is the definition of history? History is study of past in light of present to have good future. Am I right? आप हर वक्त पूछते हो ना पेशेंट का क्या हिस्ट्री है, क्या हिस्ट्री है. So she is narrating what is happening past. कब narrate कर रही है? Today. क्यों? To have good future. So history is study of past in light of present to have good future. This is new technique of holding mind. So she is complaining of mild abdominal pain, no vaginal bleeding, body temperature is normal, BP is 130/90, her heart rate is also normal. If you dig into the history of family, her brother has got DVT, sister has got 2 preterm with preeclampsia. Okay? Then biochemical investigation. आप सब लोग भेज देते हो, चलो she has got recurrent pregnancy loss. जितने आते हैं दिमाग में, जितने लेबोरेटरी वाले करते हैं, जितने अपने दोस्त हैं पैथोलॉजिस्ट, सबको भी खाना है ना, तो सब इन्वेस्टिगेशन आप लिखोगे तो आपने अपना लिख दिया, वो नेगेटिव है. पीसीओ का किया, LH, FSH, प्रोलेक्टिन, it will be prolactin is otherwise normal. What you are looking in thyroid, मैडम, ये बाजू स्टूडेंट और ये बाजू इंटरनेट, बराबर. तो स्टूडेंट के पास याद आ जाएगा, मैडम क्या लग रहा है, ये देखिए हाइपो लग रहा है, हाइपर लग रहा है. बोलो बोलो, TSH ज्यादा है तो क्या लग रहा है, हाइपोथायरॉयडिज्म. ये डायबिटीज के लिए कोई बोलेगा जीडीएम लग रहा है, हाँ, HbA1 थोड़ा ज्यादा है. फिर उसका इन्फेक्शन के लिए किया, कैरियोटाइप किया, सब नॉर्मल है. 2 चीज अपने को पॉजिटिव मिली, वन इज डायबिटीज एंड सेकंड इज हाइपोथायरॉयडिज्म. ओके. अभी इसके पहले जब पेशेंट के प्रीवियस टू एबॉर्शन हुए थे, यू वुड लाइक टू रूल आउट सर्टेन थिंग्स लाइक वी हैड डन फॉर मेल. मेल के लिए क्या कर सकते हैं, स्पर्म एग्जामिनेशन, स्पर्म डीएनए फ्रेगमेंटेशन. अपने रेडियोलॉजी को भी थोड़ा फीड करना है तो उसके लिए हमने HSG किया, MRI किया, यूट्रस का एंडोमेट्रियम देखा, 3D किया. Recently we have published paper that hysteroscopy is virtually replaced by good 3D ultrasound. You can have a virtual hysteroscopy, you can see post-postia, you can see very good endometrium, you can see vascularity. HSG किया था, अभी तो नहीं करते लेकिन किया, both tubes are normal. So woman is dependent on her physician. Afterwards, आप जब physician होंगे, सब होंगे ना, आज नहीं तो कल अपना भी दिन आएगा. ओके, तो आप कंसल्टेंट होगे तो उसकी लाइफ और उसके बच्चे की लाइफ आपके ऊपर डिपेंड करती है. तो आप क्या क्या बैटरी ऑफ इन्वेस्टिगेशन उसके साथ कर सकते हैं. क्रोमोसोमल एब्नॉर्मलिटी चेक कर सकते हैं, उसके लिए क्या करेंगे, पीजीडी करेंगे. एनाटॉमिकल एब्नॉर्मलिटी के सर्जिकल ट्रीटमेंट करेंगे. थ्रोम्बोपिलिया है तो क्या देंगे, अनफ्रैक्शनेट हिपेरिन और लो मोलेक्युलर हिपेरिन और लो डोज ऑफ एस्पिरिन. इन्फेक्शन है तो क्या देंगे, डॉक्सीसाइक्लिन फॉर एटलीस्ट 15 days to 1 month. एंडोक्राइनोलॉजिकल कॉज के लिए आप देखेंगे कि डायबिटीज है, हाइपोथायरॉइड है, हाइपरप्रोलेक्टिनिमिया है. मेल के लिए तो एक ही चीज है भैया, लाइफस्टाइल मॉडिफिकेशन, एंटीऑक्सीडेंट, क्विट स्मोकिंग, रिमूव ऑल द वाइसेस एंड रिमेन नियर टू वाइफ. थैंक यू. अनएक्सप्लेन के लिए प्रोजेस्टेरोन और जनरल आप मेंटेन दी नॉर्मल हेल्थ. विटामिन डी सप्लीमेंटेशन, विटामिन डी has got very good role in infertility. So always see that vitamin D, vitamin B12 should be good. And recently WHO has recognized our therapy of engagement pill. Anybody can name what is engagement pill? Another 100 rupees in. चलो 500 बना दिया. What you call it as an engagement pill? Everybody knows. इधर है लेकिन इधर नहीं आ रहा है. It is 5 milligram of folic acid. Whenever she gets engaged, start 5 milligram of folic acid to prevent neural tip defect. You can prevent only NTD with increasing dose of 5 milligram folic acid or tetrahydrofolate, dihydrofolate, whatsoever you like. So this is known as engagement pill. अभी डॉक्टर है, किसी का engagement हुआ तो इसको दे दो कि मेरी तरफ से 30 tablet of folic acid. Because in future कोई इन्वेस्टमेंट है मैडम, 30 गोली का ज्यादा पैसा नहीं लगता है, फ्यूचर में आपके पास आएगी, वो डॉक्टर ने मेरे को दिया था 30 गोली. ठीक है, so it is an engagement pill. So we have given her levothyroxine. Madam has rightly said it is a hypothyroidism. Her sister has got preeclampsia. First line of treatment is levetolol. Still methyldopa is available in Nepal. In India it is in subsidiary rate, so we are getting methyldopa and levodopa, levetolol. Okay, so methyldopa is first line of treatment. If it is not good, it is not controlled, you can use levetolol also. Levetolol has got liberty to use up to 1002 milligram. Okay, 1200 दे सकते हैं, start with 100, 200 BD, PID, and you can control the blood pressure. And levetolol injection is very good in PH. When there is eclampsia, you can use levetolol injection. Progesterone supplementation, because she has got 3 previous miscarriage without any cause, so you can start with progesterone, folic acid, and C is GDM. So you can start with metformin. Metformin has got very good role in PCOD as well as gestational diabetes. So why you are using progesterone in this particular case? If you name the hormone progesterone, means it is pro for gestation. It is the only hormone which will give us birth into this exterior. We must thank our mother. Madam will agree with me. We must thank our mother that our mother has generated enough amount of endogenous progesterone to nurture us. If it is not that, then we will put it from outside. Yes, yes.
About aspirin, any rule?
Aspirin. I will say aspirin has got very good role in APLA, and aspirin has got very good role in PH. Latest theory of PH, student. What is the latest theory of PH? Vascular invasion. Madam, I will say that whenever there is implantation, just narrate like this. Ovum is resting in the garden of Ambula. Am I right? Single ovum resting in the garden of Ambula, waiting for handsome. 3 Idiots कितने देखा था? Life is like a race. 3 Idiots देखी थी? हाँ, इसमें था Life is like a race. तो सब साले बंदे जाते हैं. उसमें से एक ही चूज होता है. Then it's shut down. Then it is converted into 2 cell, 3 cell, 4 cell. 3 cell होता है. मोरो तो सही नहीं होता है. बाइनरी होता है. 2, 4, 8. मोरुला होता है. मोरुला will implant into the endometrium. We are implanting ourselves intrinsically into the endometrium. We are eroding our mother's endometrium. बोलते हैं सारा मेरा खून पी गया. बचपन से पीता है. इन यूट्रो से पीता है. सही है ना? वो खून पी के तो अंदर जाते हैं. We are implanting ourselves by eroding the endometrium. Madam, here theory comes. When it is erodation, it will be done by syncytotrophoblast and cytotrophoblast. They have got phagocytic activity. This syncytotrophoblast and cytotrophoblast going right up to the uterine artery. How many of you had cut the uterine artery during cesarean section and cut the uterine artery during hysterectomy? What is the difference? क्या है hysterectomy क्या है? Cesarean में uterine artery cut हुई. What is the difference? Simple difference.
More muscular.
It is more vascular, but diameter is more and flow is less. यदि hysterectomy में कटा तो पूरा चश्मे तक जाएगा, और cesarean में कटा तो हाथ तक ही रहेगा. ये क्यों? कभी सोचा? Because this syncytotrophoblast and cytotrophoblast has got phagocytic activity and they are phagocyting the muscular cord of uterine artery. That's why uterine artery has got notch. For any things to contract, there must be muscular. So if you see any artery, there is enigma, media and serosa. Media is made up of muscle. And that muscular cord is phagocyted by syncytotrophoblast and cytotrophoblast. So latest theory of PIH is improper phagocytosis by of uterine artery by trophoblastic cell. That is the latest. So what you have to do, madam, aspirin. If you give aspirin, they will make the vasodilatation, antiplatelet activity. And second, you can use arginic acid. That is L-arginine. Nowadays available as a 3-gram sachet in every company. So how arginine will act? When arginine will convert it into citrulline, they will produce NO, nitric oxide. That is nascent nitric oxide, and it is a potent vasodilator. So if you want to use aspirin in PIH, always use starting from first trimester, because once presentation is formed, this aspirin won't help. It won't go into the uterine artery. You understand my point? So if you want to start aspirin, you have to start aspirin pre-pregnancy or just say diagnosed as a pregnancy and see a case of pre-eclampsia, you can start with aspirin 150 milligram. And at which time you have to give aspirin? Anytime? Always give aspirin at a bedtime because body has to circadian rhythm. So always give 150 milligram aspirin at bedtime in all the cases of suspected pregnancy-induced hypertension, or there is a mild hypertension, or there is a case of APLA. You can use aspirin. And when I was studying, there is a class study, CLSP, collaborative study of low-dose aspirin in pregnancy. Every study has got its name. That's why study is named Champion trial, it has got name. Promise trial, it has got its name. Derived from its all mnemonics. आपके पास वो बुक आती है कि नहीं mnemonics की, छोटे-छोटे, grading the papilloedema, तो याद रखिएगा night nurses have pimples, narrowing, making and papilloedema. ऐसे बुक्स आती थी, इंडिया में मिलती है. How to remember all the different causes. इसको बोलते हैं mnemonics का बुक. छोटा सा आता है. It will narrate all the causes, just like suppose immunoglobulins है, तो GAMD, gamma, IgG, IgL, L is bad, G is good. Whenever there is infection, M starts. Manish will get there. Then there will be G. G is God. Can you give me the definition of God? Why God is always capital? G-O-D. It is generator, observer and destroyer. Brahma, Vishnu and Mahesh. That is G-O-D. That's why always G-O-D is in capital. You never write G-O-D in small letter because it is not a word. It is a sentence. Generator, observer, destroyer. Madam, can you satisfy my answer with aspirin? Madam, aspirin के लिए answer is okay? You can give double. You can give double. Because why it is 75 milligram? Because you are following WHO. And WHO is always giving 75 milligram because it is from the class study. Collaborative study of low dose aspirin in pregnancy. But nowadays our every requirement is increasing. So latest dose was 150 milligram at bedtime in suspected cases of PIH.
Now again going to the progesterone. Progesterone is also called the pregnancy hormone. This is very good sentence. Women with less than 35 nanomilligram progesterone are 23 times more likely to experience miscarriage. This is also mentioned in our Krab book that inadequate progesterone will lead to miscarriage. So progesterone we know all secreted from corpus luteum, then afterwards it will be taken by placenta. How placenta forms? Placenta is just like different parts of Nepal, Baramati, different cotyledons. Why God has given different cotyledons? Because if suppose one cotyledon has got infarct, birth will be taken by second cotyledon. So whenever we implant, again cytotrophoblast, cytotrophoblast, then there is formation of chorionic villi. Condensation of chorionic villi known as chorionic frondosum. Condensation of chorionic frondosum becomes cotyledon, and condensation of cotyledons becomes placenta. And placenta is our root from which we get all our food, nutrients and everything. So progesterone helps in maintaining the pregnancy and it will be taken by 10 to 12 weeks. So progesterone supplementation begin in the first trimester. If see the case of recurrent pregnancy loss, you can use progesterone post IUI or post time intercourse also. This is not going to harm. Okay? These are the different surveys in 2029. Cochrane review said that progesterone supplementation on recurrent pregnancy loss reduces the rate of pregnancy losses. Promise trial. Everybody knows Promise trial was a big trial. The live birth rate was 65.8 in progesterone compared to 63.
Prison trial, 30 pre-book gestation was 75. 2020 meta-analysis, they said 75% increasing if you use placebo against progesterone. So if you use progesterone, they are always going to help, because if you see all the papers, 63, 75, 78% increase will be there. So progesterone deficiency is one of the vital modifiers of this factor, because you can't change the crop, you can't change the soil, you can't change the sperm and ovum. Only thing you can change the fertilizer. If you see pregnancy, it's just like a cultivation. Okay, you can't change the farm, because you can't change sperm and ovum. You can't change, but only you change you can do is progesterone, giving good fertilizer. Because progesterone is required. And if you see, since the genesis of ossipil, madam, we are using ossipil since years together, madam. What is the change in estrogen? No change. एथिलीन पिंकस ने जितना निकाला था उसने थोड़ा कम किया 0.02 to 0.03. But all different varieties of progesterone are there. Why? Because the things has got maximum effect, has got maximum side effects. And why there is little bit innovation in progesterone? Because we want least side effect progesterone. Desogestrel, spironolactone, all these are there. Prosperinone, then desogestrone, all are different variety of progesterone. You can get different 17 variety of progesterone, starting from norethindrone, norepinephrine, all different variety of progesterone are there. And every people will give you one paper of money which is describing all different type of progesterone. कथा मैडम इन लोगों को दे रहे हैं ना बाद में. Yes, thank you. अभी बोल दिया तो बोल दिया, अभी नहीं. अभी तो जाहिर में बोल दिया. Thank you. So progesterone types. We have the different progesterone available in market. You all know intramuscular, hydroxyprogesterone, capriate. These people are marketing Pro9. You can have a micronized vaginal progesterone, micronized vaginal pessaries, oral micronized progesterone, and oral dihydrogesterone. There is not a single paper in the literature says that oral micronized progesterone has got any value. I am speaking of dihydrogesterone since 2000. This is my 23 year of speaking of dihydrogesterone. In 2000 when I am speaking of dihydrogesterone, nobody believes. Nowadays more than 60 companies are taking dihydrogesterone. And I am happy to say 48 companies using my drug. So dihydrogesterone is the molecule which is a retroprogesterone, which is more nearer to the nature. So oral dihydrogesterone, oral micronized progesterone, it is approved only for secondary amenorrhea. Metabolites may affect in pregnancy outcome. Metabolites can cause dizziness. Metabolites can affect the progesterone reaction. So what is the drawback of vaginal progesterone? Because our female, I don't know about the Nepal, in India our female don't want to put anything inside the rectum or vagina. They always want to take oral. What is the scenario in Nepal? Say, because it is a neighboring country now. Western world, they are taking everything and they are putting everything below. There are all of the different facilities available worldwide, and because I don't know, they are happy. So it can cause insufficient vaginal irritation, uncomfortable, difficult to handle, and possibility of yeast infection. Sometimes the color of that tablet, if you get discharged, patient will say, "Madam, yellow color, red color I have." And so many times, some companies are not good. You can find a plug of tablet vaginal capsules in the vagina. Once you see perspective examination, there will be big ball-like thing, because every day they are putting vaginal tablet and they are not properly absorbed, because they all are on the pH of vagina dependent, and vaginal pH is not every day same for every woman. That's why recently we have got very good discussion in essay of microbiome. It is very good. Healthy vaginal flora will also one of the cause of recurrent pregnancy loss. If you don't have healthy vaginal flora, if bacteria is not good, then there will be a recurrent pregnancy loss. Now what they are doing, they are taking healthy microbiota from the healthy vagina of a healthy young volunteer, and they are putting this secretion into the vagina of affected woman, and they are getting very good result. So this is also one of the cause by which this is one of the latest question. Somebody says, what is the latest innovation in recurrent pregnancy loss? This is making vagina healthy. That's why probiotics are available in market. Intramuscular injection, we all know risk of cellulitis, acute esophageal pneumonia, slow clearance. There is sterile abscess. There will be bleeding in the muscle, pain at the injection site, and all IVF specialists has got worst thing in their practice is intramuscular progesterone injection. Am I right, madam? तो पेशेंट ऐसे ऐसे चलते आते मालूम हो जाता है ये आईवीएफ की पेशेंट और बैठा होता है ऐसे धीरे से बैठे मैंने विटनेस सो मेनी पेशेंट लाइक दैट मैंने सही बात है बोले मैं सब कुछ ठीक है प्रेगनेंसी रहेगी लेकिन मेरे रोज की सुई मेरे को परेशान कर So what is the rationale? We are going to use oral dihydrogesterone because oral dihydrogesterone is selective for progesterone receptor and 1.5 times better than micronized progesterone. Bioavailability of progesterone is 5 to 6 times better than oral micronized progesterone. Oral micronized progesterone is not indicated for threatened abortion. Here, dihydrogesterone you can use in threatened abortion 40 mg state, 20 mg till bleeding stops. Dihydrogesterone reaches exact site at the endometrium within 30 minutes and will range for 5 to 7 hours. And this is the paper madam I am talking about in 2016. This is Pandya MR paper and thanks Evan for including this paper in your slide. This is paper will be given by you by Katha, which is progesterone supplementation during the treatment of first trimester. And in here we have done study of 31 different papers starting from 1980 to 2015 because this paper was published in 2016. All different varieties of progesterone available in market and what is their role and what we can use in infertility. And this is the end result. In IUI you can use dihydrogesterone has got greater affinity of 85%. So in IVF you can use dihydrogesterone compared to oral micronized progesterone. It has got little bit higher reach. And because of this publication, 500 paper was asked by American government for this. So you can use benefits of oral dihydrogesterone, no separation of pituitary gonadales. So we don't want separation. We also want natural endogenous estrogen and progesterone should come. And when pregnancy is there, all progesterone is coming from the placenta or corpus luteum, but that will be controlled by hypothalamus. It will give that now you release progesterone, now you release thyroid, small tiny things, hypothalamus. It will give control to the master orchestra of pituitary. And there will be HPOU axis, hypothalamus, pituitary, ovarian, uterine axis. We all are here because we have got 4 acres on the estrogen, progesterone, FSH, and LH. If you ask any IVF specialist, they will be mastering in these four hormones: FSH, LH, estrogen, and progesterone. इसके अलावा कुछ है नहीं एक्स्ट्रा में थायराइड, डायबिटीज हो सकते हो 0.001%. So it reduces innovation of injectable नहीं देना है. High bioavailability causes endometrial transformation at the dose of 20 to 10 to 25 lower doses. Ideal dose of micronized progesterone in IVF is 400 mg BD. So 800 mg you have to put into the vagina. Tablets are available 100 to 200. How many tablets you have to put? So there is vagina, there is odam. You can understand 800 mg of 100 mg tablet, 800 you have to put in vagina, then it will be quite high. Nowadays people are making 400 tablet also. But minimize side effect with given disturbance in dihydrogesterone, high selectivity of progesterone receptor. Again, this paper was published in Indian Journal by me, and you can get this paper. This is study of oral dihydrogesterone by Das and al. In this presentation, I have taken almost all references from India only. Because till now we have got habit that white people are good. All the papers are from whites are good, but now India is also producing lots of paper. And I see so much potential in Nepali children also, Nepali students also. You can have all your good work, and sir is publishing your data in FIGO, Paris. With Clapper, sir, he is going in FIGO, and he is presenting the MMR data, maternal mortality data, and giving presentation in Paris. I am not fortunate enough, but he is fortunate enough. So you see, so this is study from Das. He had done 100 patient study in which he had given oral dihydrogesterone and vaginal progesterone 600 mg. Whenever you do study, there will be 2 arms, one is progesterone, one is dihydrogesterone. Study design 50-50 patient each. Significant variation, cessation of vaginal bleeding, everything they studied. And what ultimately they found? Oral dihydrogesterone is better in preventing vaginal bleeding and prolonging the viability of pregnancy till end. Okay, this is again paper by Kala. This is Kale. This is our 2 husband and wife. Ashish Kale and his wife and her mother-in-law. This is paper of them. They have done 200 patient study with history of minimum 2 pregnancy loss with vaginal bleeding. Again, 2 group, 30 mg oral dydrogesterone and 600 mg vaginal tablet. Mean time required for cessation of bleeding. So once bleeding stops, this we can use in preterm abortion. When there is a threat, there is a bleeding, but baby is blind, no sign of expulsion. There might be reproplacental clot. We can use this and continuation of pregnancy up to 24 weeks. Results are very encouraging. Dydrogesterone required 43 times less time bleeding. Barabar? Dydrogesterone is 5 times higher in continuation of pregnancy, 9 times higher in continuation of compared to vaginal bleeding, lesser time for completing stoppage, and high viability of pregnancy. Then again, we are all European guideline, FOXI guideline, X-ray guideline. All this committee guidelines, that woman presenting with clinical diagnosis, we have to use progesterone. FOXI statement, 10 milligram BD, my presentation is there in Manish 4 to 6, 9, 20 till 20, और 20 रेटिंग करते हैं। इधर क्या नेपाल की टीम होती है अभी एशिया कप, ये वो नेपाल टीम आई सी, नेपाल टीम was there in Asia Cup. So 2020, use remember 20 till 20, 20 milligram of dydrogesterone till 20 week of gestation. X-ray guideline, they are also saying that you have to use progesterone. And I am fortunate enough that it is a part of FOXI progesterone statement, that is 2015, and one of the part from Surendranagar. Recently, we had made guideline on progesterone in endometriosis. You can use dydrogesterone in young endometriotic girl rather than dinogests. It will be very good. This guideline will also come, and this is the paper of Grisinger in 2018. What we had proven? Non-inferiority of dydrogesterone. When you want to compare anything to the child in market, one is micronized and one is dydrogesterone. Anybody knows micronized and dydrogesterone both are coming from the same mother? It is Dysphoria villosa is the plant origin. From plant, if they convert it into micronization, it becomes micronized progesterone. And once it got into the retroprogesterone, it becomes dydrogesterone. So if we say एक ही माँ के दो बच्चे, एक है राम तो एक है लखन, तो या तो दोनों नेचुरल है या दोनों सिंथेटिक। माइक्रोनाइज वाले क्या बोलते हैं? डाइड्रोजेस्टेरोन सिंथेटिक है। डाइड्रोजेस्टेरोन वाले क्या बोलते हैं? माइक्रोनाइज वो सिंथेटिक। दोनों एक ही माँ के हैं, बोथ आर कमिंग फ्रॉम द नेचुरल सोर्स। और आप लोगों को तो प्राउड होना चाहिए, नेपाल और चाइना में डिस्कोरिया विलोसा मिलता है, मालूम? कथा है मेरे, नेपाल और चाइना से अपना डिस्कोरिया विलोसा का प्लांट प्रोकेटा लाता। वर्ल्ड वाइड डाइड्रोजेस्टेरोन चाइना में भी बनता है, तो उसका इंडिया और चाइना में, नेपाल और चाइना में से ही प्रोकेटा जाता है। और प्रोकेटा इज द मेन थिंग, जैसे ये बॉस, उसके बाद में उसके डिफरेंट जनरेशन निकलते हैं। दिस इज अ डिफरेंट प्रोसेस। If you want to make dydrogesterone, then there are 3 different processes. You can have a proton bombardment, you can have a chemical bonding, and dydrogesterone made in Netherlands, they are using the UV light bonding. So you have to break the bond. So you have to make retroprogesterone, and this is very good for pregnancy continuation because it's just like your natural progesterone. Different society, Saudi Arabian society, Royal society, guidelines for RPL, DGGS, SGGG, PICO, everybody says that you have to use progesterone for recurrent pregnancy loss. So why dydrogesterone used in recurrent pregnancy loss? The question is, there are so different varieties of progesterone available in market. Professor Raj Raghupati has given very good notion of allogenic immune response to maternal antigen. Can anybody know what is that? Allogenic immune response to paternal antigen. You all know we are all born from sperm from our father and womb from our mother. Okay? So 23, going into the uterus become 46. So many times, uterus recognize this sperm as an antigen. Now COVID has taught us antigen antibody reaction. You all know, whenever antigen antibody reaction will come, there will be formation of T and lymphocyte. This all protective lymphocytes will be there. They are making antibody reaction. There will be 2 response in our body, Th1 type and Th2 type. Second MBBS forensic Robbins pathology. याद है ना? तो Th1 and Th2. Th1 is always destructive. Th1 is always protective. Whenever there is formation of Th1 cytokines, it is an abortive. There will be formation of symmetric antibody. There will be bind with just like lock and key. There will be formation of destructive cytokines and there will be inflammatory process. So uterus will decide that this pregnancy I can't continue. But we have to thank our mother and our body that our body has generated enough amount of Th2 cytokines. That is the protective cytokines. There is a asymmetric antibody. There is a formation of less natural killer cells, less destructive cells, and there will be anti-inflammatory or pregnancy protective immunomodulation is done by dydrogesterone, and this is proven by Professor Raj. So if you use oral dydrogesterone, there will be immunomodulatory effect. It will be increasing PIDA production. What is PIDA? Pregnancy-induced blocking factor. Increases cytokine shift towards Th2. Th2 is good. Th1 is bad. Th2 is good. So it reduces cytokine and natural killer cyclic activity, express foreign antigen, normal system, stimulate nitric oxide. Similarly, has done very good study. If you use increasing dose of dydrogesterone, there will be increasing P receptor cell in your body. If me say it is not right. They have done study on all the placenta. They have taken the blood from the cord and they have seen that those patients who has taken good amount of dydrogesterone, 20 milligram till 34 week of gestation, they found that P positive receptor cell are there more number in the patient who has taken dydrogesterone. And again, whenever you are taking dydrogesterone, same effect, arginine converted into citrulline, that is formation of special nitric oxide, and nitric oxide is potent vasodilator. And we want what we want in different pregnancy loss and PH, good amount of vascularity, good amount of blood should reach to the uterine endometrium. And this is Professor Raj. He has been to Kuwait and he is doing very good study in Kuwait. So immunomodulatory effect, what is progesterone and dydrogesterone? It has got direct effect of increasing anti-inflammatory and decreasing pro-inflammatory. Decreasing pro-inflammatory means Th2 increase, Th1 decrease. Okay? So progesterone is blocking factor and there will be successful pregnancy. There is a very good study by Kasayan et al. And the aim of this study to prove that, to investigate that, if suppose I am saying that dydrogesterone is increasing your immunomodulation, everything should be proven by laboratory testing. So this is very good study. They have to investigate the ability of progesterone and dydrogesterone molecule, cytokine production by PMBC, that is polymorphonuclear basic cells, to women undergoing recurrent pregnancy loss. What they have done, they have taken this cell from 22 female with unexplained recurrent pregnancy loss, stimulated with 5-HT in the presence or absence of progesterone, and what they found, they assessed for all tumor necrosis factor, tumor factor gamma, interleukin 2, 6, 10, 13, 17, 8, 23 by ELISA. Results were that progesterone and dydrogesterone significantly downregulate the secretion of Th1 cytokines. Again, Th1 cytokines are abortive. So Th1 cytokines are decreasing and there is a protective shift of regulation of all protective cytokines like Th17, interleukin 7, interleukin 23. So they concluded that anti-inflammatory effect of Th2 cytokines are associated with healthy pregnancy. Pro-inflammatory Th1 and Th17 cytokines are associated with pregnancy miscarriage. So progesterone can alter this maternal cytokine profile to manage the pregnancy complication. So if you use dydrogesterone, you can have this all positive effect. This is very good study by Ghosh and all. Again, this is our Indian study. They have taken dydrogesterone 10 mg daily for 4 weeks, micronized progesterone 100 mg for 4 weeks, and control group they have given nothing. So this is just a control group. What they found? Reduction in the implicit resistance index, that is RI. Nowadays everybody is looking RI. RI is what? Systole, diastole, and mean is RI. Okay. So reduction in RI and PI both if you use dydrogesterone, improve uterine blood flow, increase nitric oxide production, so 45% lesser miscarriage if you use dydrogesterone compared to micronized vaginal progesterone. And these all are different analysis. If you see SS done 3 study, 2003, 2013 and 2019, all different meta-analysis, they say that if you want to reduce the miscarriage rate, you have to use dydrogesterone. So in present case, choosing oral dydrogesterone. Nowadays I think that so many generic companies are there in your Nepali market. They have said that they are selling at 75 rupees and they are selling at only 50 rupees or 40 rupees. It is that they came to your market or not? They are out, they will come soon. Okay? So what is the safety and tolerability of dydrogesterone in pregnancy? No significant side effect. Because this dydrogesterone available in market since 1960, 9 years before I born. So many kids born worldwide, 20 million babies. Nobody has got any congenital side effect. So less estrogenic, androgenic, anabolic effect, no significant side effect, no muscular irritation, significant fewer cases of diabetes, no dizziness, vomiting, giddiness, bloating. And these are the different studies from 2005 to 2021. All are different studies, and biggest study is by Grisinger. Grisinger's study was double-blind, double-dummy study. What do you mean by double-blind, double-dummy? Even investigators don't know which drug they are giving. Even patients don't know what they are putting. So every patient are putting 10 milligram dydrogesterone 3 times a day. Every patient are putting 400 milligram capsule into the vagina. So patients are taking both macronized as well as dydrogesterone. But one is placebo. Even innovator don't know. If suppose you are doing, you don't know which patient is taking dydrogesterone. So first time in world they have done double-blind, double-dummy study, and it is world's largest study of 1,034 patients, and they have proven that dydrogesterone is non-inferior to macronized progesterone. They are not saying superior. It is non-inferior to macronized progesterone, and they get mixed result after using dydrogesterone. So this is all are different studies by Professor Kelly and all. And if you see this is odd chart. In your study you are making is an odd chart, and you see this diamond. If this diamond towards dydrogesterone means it favors, but if on this negative side it doesn't favor. So all this study, all different study from 2005 to 2021, they say that dydrogesterone is very good compared to macronized progesterone. So there are lots of clinical benefits. If you compare the efficacy of supportive therapy dydrogesterone in HCG, it is very good. This is very old study by Al-Zibay in 2005. In 2005, it was published in Endocrine Journal. They use oral dydrogesterone compared with intramuscular HCG. Believe me, the HCG is always working as a secondary effect. For HCG to work, there should be very good corpus luteum. If corpus luteum is good, then progesterone production will be good. If corpus luteum is not good, then progesterone production will not be good. And in this type of cases, if you are HCG don't work. Because it has to work on the corpus luteum, and then a corpus luteum will produce progesterone. Because HCG is what? It is LH. That's why we are using HCG in womb triggering. We are giving HCG to give the LH surge. So HCG is equal to LH. So if you want to use LH, there should be very good corpus luteum. So Professor Al-Zibay has supported that dydrogesterone you use, there is no adverse effect and there will be successful pregnancy. And this was the aim of study by Hassan et al. That if you want to decrease the miscarriage, use dydrogesterone in all this your patients. This is different variety of 13 different reports. Number of subsequent miscarriage will be less, 10.5% less miscarriage, and bond ratio is very good if you are using dydrogesterone. And this all study by published by Professor Howard Karp, and Howard Karp has written books on recurrent pregnancy loss. Also dydrogesterone, this is Kumar et al. Again by Indian study. They have used of TH2 and TH1 cytokines, and they say that between oral dydrogesterone and placebo, oral dydrogesterone is very good. This is again study by Yang et al. They have used study in 1,340 women. Dual therapy with macronized progesterone. They say that oral dydrogesterone is very good compared to vaginal progesterone. Again, this is study by Newman et al. The study design was very good. They used dydrogesterone and 20 alpha dihydrodydrogesterone plasma level in embryo transfer in the patients. Whenever you are using not proper dydrogesterone, this generic dydrogesterone may convert it into 2-dihydrodydrogesterone. And 2-dihydrodydrogesterone is carcinogenic. It is progesterone, but it is not real progesterone. So never misguide. In India also, before few years, there are one company who is marketing dydrogesterone, but it has proven that it is not dydrogesterone, it is 2-dihydrodydrogesterone, and that will be a carcinogenic. So don't use this type of things in your practice. This study says that lower level of dydrogesterone and dihydrodydrogesterone associated with continuation of pregnancy. So clinical benefits are there with oral dydrogesterone to make good treatment choice in pregnancy or recurrent pregnancy loss. So we have to choose dydrogesterone where life matters. And this is about dydrogesterone. You can see there is a breaking a bone. First paper was published in 1960. More than 110 countries are marketing. Demands grew from few centers to worldwide, and it is only produced in Netherlands, only in Wales. And this is only falsified medicines are not there. 9 successful items will be there, and this is only drug published with safety data. This is Toronto research. 6-dehydrodydrogesterone is carcinogenic, impairing fertility, and harm unborn child. If you see, about dydrogesterone is with least impurity, so only with high purity and standard. This is certificate of sustainability. It is also published in supplied in European countries that all granted dydrogesterone by all this support. Ever dydrogesterone is the only dydrogesterone which is supported in 1945 that you can use this dydrogesterone in recurrent pregnancy loss. So ever dydrogesterone is certified. None of the dydrogesterone certified by European Pharmacopoeia. More than 600 articles are there. Still generic dydrogesterone yet to publish any, but is the number one. More than 2 crore pregnancy and more than 600 public articles are there. So use innovator dydrogesterone because it is available in market since last 60 years. Low progesterone level risk, all treatment options are available. OXY guideline in 2015. Progesterone also gives PIDA, PH2 cytokines are increasing in the anti-inflammatory effect, multiple benefits. Clinical evidence always says that miscarriage rate is very low. So about dydrogesterone is trusted product and backed by evidence. In critical situations like threatened abortion, recurrent pregnancy loss, butyl-based support, always use a right choice with innovator dydrogesterone. I am happy that I have used this Netherlands facility twice to see all this facility, and this is recent X-ray picture. Recently I published my poster in X-ray. This was paper in X-ray publication. So man needs this difficulty because they are necessary to enjoy the success. And these are the different GIF made by different company on dydrogesterone. You can see this is different dydrogesterone GIF made by different company. You can see all this paper of IMR right over here. So thank you very much. Thank you. And this is very good said by Balaji. Is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. अब सबके को क्या करना है? The time to be happy is now, and the place to be happy is here. And the way to be happy is to make someone happy and have a little heaven right here. Thank you very much. Thank you, Oscar, for giving some upkar on me to be over here to pay my homage to Pashupatinath. Any question regarding this is welcome.
No, sir.
When there is no question, there are 2 things. Everything is gone in your mind, but everything goes above the mind. So thank you. Yes, madam.
And third question is, if you want to start probiotics, in some cases, randomly can you start probiotics or no?
So madam had asked 1 question with 3 questions. First is vitamin D. Vitamin D is always helpful. Now you see, in India, vitamin D testing is little bit costly, 800 to 1000 rupees. And the cost of treatment of vitamin D is 200 rupees. 8 tablets, 60,000 twice weekly. So if you give empirically, if I measure vitamin D of your, only few people has got 100% vitamin D in normal range. Why? Because we are sitting in AC, we are not going outside. You all know that vitamin D is always synthesized from sunlight. How many of you have taken sunlight since last 1 year? धूप में भी नहीं खड़े रहते। सनलाइट के लिए आपको चाहिए सुबह वाला धूप। Transitional sun rays come to your body, and for that you have to go to the beach. We are watching beach only in mobile. Seeing beautiful woman lying on the beach. So if we measure vitamin B12, vitamin D3 of ourselves, it will be less. So you are answering your question. If you start empirically vitamin B12 or infertility patient, it is not going to. Second thing, there is no hypervitaminosis D. It was always excreted from the urine. So you can use. Second question, with vitamin D you can use C and E also. You can, but C and E has not that much proven role in infertility. E has got very proven role in mastitis. That is proven, but E has got not proven role in uterus and endometrium. Vitamin C doesn't have that proven role. But vitamin C is always good because whenever iron wants to get absorbed, it always absorbs on the backbone of vitamin C. So if vitamin C is there, there will be no proper iron absorption because mucosal cell once from Fe plus 2 to Fe plus 3, there will be vitamin C should be there. So you can use this. Third question, probiotic. In so many types, if you see vaginal pH is not good. Vaginal pH is not good. Then you can see that frequent vaginal infection, recurrent vaginal infection, irritation, discharge, and patient comes with infertility. In this type of patient, you can use probiotic without any investigation, number one. Because how you investigate vaginal probiotic? So to take vaginal smear, you have to send to the laboratory. Previously, in our residency days, we are doing the study. We are taking the superficial cell, intermediate cell, and we are measuring the data, stratified, and nowadays nobody is doing. You can start all this thing empirically without investigation also. That is not going to harm. Rather than spending on vitamin D investigation, you can spend same money in vitamin D3 tablet. And nowadays very good nano stores are available. Vitamin D3 nano stores are available, which gives 100% good result. Any question? Okay? Thank you. Yes, ma'am.
I'm just three questions.
Yeah, madam.
There is one question regarding IVF. Many women who have done IVF, they complain of recurrent vaginal bleeding. So what can we do for this problem? I have experienced that.
Recurrent vaginal bleeding post embryo transfer or post diagnosed pregnancy. Post embryo transfer. If suppose it is post embryo transfer, means your embryo transfer technique is not good. Simple. Because post transfer bleeding should not occur. If your embryo transfer technique is adequate, you have taken the cervical mucus out, you have judged the uterine endometrium size, you have judged your point of insertion of putting the embryo. Everybody knows what is MIP point? Maximum implantation potential point. Every uterus has got different MIP point. If you see, uterus has got two tube level. If you make a true line at this tube level, and when this line meets, this is your maximum implantation potential point. If you put your embryo at this center, there will be highest chance of pregnancy because we are putting ourselves by dropping down from the endometrium. So when it drops down at the center, either from right or left. So every uterus, biconate uterus, uniconate uterus, saccate uterus, RPL uterus, every uterus has got different MIP point. So post embryo transfer bleeding, your embryo transfer technique is not good. Number two, whenever she becomes pregnant and there are chances of spotting, irritation, sac is not good, then three things. Either endometrium is not good, number two, the implantation is not good. Because here we have to support that pregnancy by UTL phase support adequately. Why? Because when you are taking ovum, you are not taking only ovum, you are also taking the granulosa cell. Granulosa cell are the mother of corpus luteum. So there will be always insufficient corpus luteum production in all IVF patients. That's why all IVF patients require adequate support of progesterone. If your progesterone support is not good, आपको ये खाना है, इससे आधा आपको दूध तो चलेगा, पूरा चाहिए. So some patient will require 30 mg dihydrogesterone, some patient will require 20 mg dihydrogesterone, some patient will also require dihydrogesterone intramuscular injection. If she has no history of previous pregnancy or even after she become pregnant with IVF, you are given only injectable. Now you are using injectable, micronized and dydrogesterone to justify the dose. So improper progesterone level is the answer of post-pregnancy or post-gestational site bleeding. Okay? Yes, anything? So मैं आप और खाने के बीच में आया हूँ, तो मैं अपने आप को विराम देता हूँ और मैं यस अरे दादा आज नहीं पूछेंगे तो कैसे चलेगा?
Thank you, sir. It's a wonderful presentation. And there is a usually confusion. We want to give, if there is a certain abortion early, very early pregnancy, like 6 weeks, 7 weeks, we are used to giving HCG because there is no nucleoplacental shift. So you are saying that we have to see the corpus luteum before we give HCG because before if corpus luteum is not functioning, so no use of giving HCG, right? So how do you decide on that?
Very wonderful question because still then everybody has got habit. Whenever there is threatened abortion, what they will do? Injection सबने ठंडक का इंजेक्शन दिया, मेंटल इंजेक्शन दिया, फिर भी उसको गिर गया. And what we will say? सब बिना मेंटल इंजेक्शन लिया था फिर भी गिर गया. Number one. How you can see corpus luteum? You can see corpus luteum. You can just put your probe towards the ovary. Either of the ovary has got corpus luteum. Put the vascularity. See that how much vascularity is there. Because whenever you are given HCG, HCG will go towards corpus luteum and then corpus luteum is making progesterone. Why there is threatened abortion? Because there is inadequate production of progesterone. So what here you have to do? You have to do the things which is working indirectly, you have to do things which is working directly. Dydrogesterone is the only drug, if you give 40 mg of dydrogesterone straight, 20 mg till bleeding stops, 43% of your threatened pregnancy can be saved. And this is proven by Professor Howard and Professor Manish that they have done study that if you use dydrogesterone 40 mg straight, 20 mg bleeding, still bleeding stop, and this is also miscarriage update, in which also there is the same type of patient with 11 week of threatened abortion. So if there is a threat, don't go for indirect progesterone increase. You have to give direct dydrogesterone. If you want to give HCG with dydrogesterone, you can give. But for that you see that progesterone, corpus luteum has got good vascularity. Corpus luteum is easily visible. Anybody has seen corpus luteum? During laparoscopy you have seen corpus luteum. During vaginal sonography you just put in early pregnancy, we never try to see the ovaries. Always try to see the adnexa. So many times you can see ovarian cyst. So many times you can see that improper corpus luteum progesterone is there. So when there is improper corpus luteum formation, supplement this pregnancy with dydrogesterone. Transvaginal sonography, see towards ovary, do minimum PRF, see the vascularity. If corpus luteum is very good vascular, there will be the flow. It will be not more than 10 cm per second. There is a very good flow and continuous flow. If there is lack of vascularity, the impedance will be low. Just you are doing your pre-IUI. You can see that corpus luteum for pre-IUI, you are seeing the uterine vascularity, you are seeing the vascularity of the ovum. When ovum is mature, how you can say ovum is mature? 18 mm, 19 mm, 20 mm, even 16 or 14 mm ovum can be mature. So for maturity of ovum, you have to see the peripheral vascularity. That's only. Peripheral vascularity. Just put the probe, see the follicle. If follicle is totally 100% vascularity is there, then it is a very good follicle. If follicle with cumulus cuforicus, again there is a very good follicle. If follicle with 50% vascularity, again it is a good follicle, but less than 50% vascularity, at that time you see the uterine artery. It will be more than 3. SD ratio will be more than 3. In this patient, if you do IUI, even the pregnancy rate will be 0. Because uterine endometrium is not proper. So this how color helps in your life. Color will add color in your infertility patient. So always do very good color Doppler in infertility. If you want to have a second time presentation, I will do whole day series on ultrasound. Sir, को बोल देना.
Thank you, sir.
Any question? अभी थोड़ा ग्लूकोज गया, थोड़ा ब्रेन स्टिमुलेटर डिफिकल्ट हुआ तो कुछ
Any
क्वेश्चन
questions regarding the particular topic?
एनी टॉपिक नॉट इनफर्टिलिटी इवन लेबर प्लेसेंटा PIH anything. I am knowing everything regarding the one uterus, one vagina, two tube and two ovum. मुझे दिल के बारे में I have got all the knowledge below the meat. दिल के लिए है कार्डियोलॉजी, वो सर आपको बताएंगे. हमारा दिल और दिल का कनेक्शन है लेकिन थोड़ा दूर दूर, क्योंकि हमारे में जो यूट्रस निकल जाता है तो गुजरात में बोलते हैं दिल निकल गया. यहाँ पे भी क्या बोलते हैं प्रोलेप्स को, माटी खस गई दिल निकल गया, क्या बोलते हैं? तो ये दिल है. हाँ प्रोलेप्स होता है यहाँ पे तो होता होगा, हमारे वहाँ पे भी स्टील प्रोलेप्स है बिकॉज ऑफ होम डिलीवरी एंड कल्लास एंड एवरीथिंग. सो थैंक यू वेरी मच मैडम, आप भी खाना खा लीजिए.
Thank you, sir, for your enriching and wonderful session.
Thank you.
Now, I would like to request our director, sir, director of uRPL Prastuti and Maternity Hospital, Sri Prasad Adhikari, sir, for his valuable words. First, I would like to request you for your words.
Thank you. Good afternoon. Thank you, Manish sir. I would like to extend heartfelt vote of thanks to our esteemed speaker, Professor Dr. Manish Pandey, who has traveled all the way from India to be with us for today's CME. I would like to thank him for delivering such an enlightening and engaging lecture today. It was indeed an insightful session, and we are truly grateful for the knowledge and expertise you have shared with us. Your passion for the subject matter is really commendable and was evident throughout the lecture. The ability of yours to simplify the complex concept made it easier for us to grasp the key points is really praiseworthy. Finally, I would like to thank you all for the audience for your patience, and to the entire team of Aboj Pharmaceutical for arranging this CME. And thank you, sir, for this is the topic we are always in confusion. Recurrent pregnancy loss and new gynecologists, all the even senior gynecologists, they are having problem with the management of recurrent pregnancy loss. So because there are so many things we cannot manage. So thank you very much for our eye opening for this recurrent pregnancy loss management. Thank you, sir.
Thank you very much, sir, and all PG students. And you can scan this ORPL ID, and you can have all my 88 presentations over there. So you can be ignited to do more research work. And worldwide, madam, only thing, money doesn't matter. Your research work. Why sir is going to FIGO? Because he has done lots of research over here. He has done service to the humanity. Otherwise, there are lots of millionaires are there in your Nepal, but nobody is representing Nepal in FIGO. So where everything matters is just your research work. You can just download this look and you will be directly into the ORCID. And how many of you are there in ORCID? Everybody heard the name of ORCID? Yes, sir. Sir is writing now. Everybody, you are in ORCID. So you can see my all 88 presentations are there in ORCID. And you also become writer. मैंने भी कभी एक ही पेपर से शुरू किया था. पहले भी हम वो टाइम्स ऑफ इंडिया वगैरह पढ़ते थे. बाद में सोचा कि ये पढ़ना भी अच्छी बात है. तो ये अपने पढ़ेंगे तो कोई अपना पढ़ेगा. You all are potential researcher. इसलिए आप यहाँ पे हो. ये बाजू में नहीं देख रहा हूँ, लोगों ने तो दो पेपर कर दिए तभी प्रोफेसर बने. आप लोगों ने तो करने पड़ते हैं ना, NCA में रेगुलेशन में है. आपको भी पीजी के लिए पेपर कंपल्सरी है. हाँ, तो ये मेरा जो जर्नल है वो स्कोपस में है. Scopus will be there for you. It will be there as well. So whenever you are in difficulty, you can contact Prasad sir and I will guide you. तो खुद काम करो, भालो भालो.